might get dark color urine, you might get abnormal circuit pressures, you might get abnormal sounds from the machine. Both the tube colors become same. There is sudden no flow, or there is a hypo or hypothermia. So for any complications that can occur during the ECMO runs, so this is what I just discussed whenever I discuss in trialing of. Whenever you want to come off ECMO, you have to first claim the return line, and when you go on ECMO, you have to remove the return line the last. Okay, that's the basic principle that you should follow in the centrifugal pump. So whenever you want to come off ECMO, you claim the arterial line first or return line, or when you want to go off on ECMO, return line has to be unclaimed in the last. Okay, that's the basic thumb rule in case of centrifugal pump. Don't try to do this with a roller pump. It is other way around. If you keep the arterial line on the roller, return line clamp on the roller pump, because of the it's a positive pressure pump. Okay, it's an occlusive pump. It causes the tube rupture. Okay, so you have to be mindful about roller pump. It's other way around.
Recording in progress.
So suddenly you can have a stoppage of pump. Okay, either it is because of power failure, or your battery is exhausted, or something wrong with the console and it stops suddenly. Okay, so what will you do? Okay, if the pump stops suddenly, what will you do? So the way your ventilator stops suddenly, what you do is you take the patient on ventilator AMBU. Similarly, if your pump stops suddenly, you have to take it on the hand crank. Just a minute. सर्किट तो लगा पहले, अरे लगा तो सही, हैंड क्रैंक तो दिखाने का है ना, हैंड क्रैंक दिखाना है ना, हाँ, तो लगा सर्किट, कम से कम हैंड क्रैंक तो दिखाओ ना. पहले मशीन चल तो वो लगा सर्किट. So, how will you manage patient on hand crank? How will you do that? Anybody wants to volunteer and do it? Now this all of you are supposed to do it tomorrow before you go home. Okay. So after the session gets over, all of you will be analyzed individually for this hand crank, because this is all those patients or all whoever may be physicians, perfusionists, they should know how to do hand cranking. Okay. So there are certain steps that you need to do it. So machine suddenly stops. So first thing you have to do is, when it stops suddenly, you have to put the clamp on the return line. Okay. When I say return line, that means anything after the pump is the return line. Okay. After the pump, that is positive pressure. So that can be a return line. So you have to put a clamp on that return line. Why? Because it is a non-occlusive pump, otherwise there will be a backflow. So put a clamp on the return line, take out the pump, put the pump in the hand crank, and start moving the hand crank, and once you are reached to RPM of more than 1000, release the clamp. These are the steps you need to follow. Okay. Again, you will be doing this practice tomorrow in the morning, and in the evening all of you have to go through this, and it should be done within 30 seconds. 30 to 40 seconds you should be able to do this. Okay. If you take more than that time, we will ask you to keep on repeating till the time you don't achieve the targets of finishing in 30 to 40 seconds. Okay. Right. So I'll just show you how we'll do that. Okay. Let them prepare it, then I'll show you that. Meanwhile, we go to the next. Okay. So that is the power failure management. Okay. The next is flow issues. Okay. In flow issues, you might get constant chattering, so flow fluctuation is too much. Okay. Or with the same RPM, the flow can decrease. Okay. So you can have a pre-pump pressure becomes more negative. With the same flow, the RPM, with the same RPM, the flow will decrease, and that can be a different reasons for that. It can be as simple as technical reason, or it can be related to the hypovolemia, patient agitated, or kink in the circuits. So you have to always see that whether it's a sudden or it's not a constant flow or it's a gradual. Invariably, when you put the patient on ECMO, initially you might get this because the patient is trying to come off from the sedation effect. He is asynchronized with ventilator, and because of that you get these problems. The moment you sedate them, they becomes fine. So if the flow is not constant, then it very likely to be patient is agitated. If it comes suddenly, there might be kink in the circuit or kink in the cannula or clot in the cannula on the venous side. If it is gradually, it can be hypovolemia, cardiac tamponade, or your cannula size can be small. Okay. So what you can see here is, you can see the rapid fluctuation in the flow. This is what, and you can see the tube movement like this. This is what we call as a chattering. Okay. Now this occurs, why? Because there is too much of suction effect, and this patient, the patient is hypovolemic. So there is no flow blood in the vessel, and because of that you can get this. So the commonest cause for this is going to be hypovolemia, or as I told you, patient is desynchronized with the ventilator. Okay. What will be your immediate management when you see a chattering? What will be the first thing you do when you see a chattering? Anybody? Yeah. The first thing you need to do is you have to decrease the RPM. Why? Because if the chattering continues, why chattering occurs? Because the vessel wall gets stuck to the cannula, okay, because of suction pressure. Now if this continues, it will cause cavitation, it will damage the endothelium, it will cause cavitation and can generate air in the circuit. So to prevent that, you have to decrease the RPM. So when you decrease the RPM, the suction effect is less, so this cannula, the vessel wall which is stuck to the cannula, get released, and that will lead to getting a better flow. So you have to keep on reducing the RPM till the time you get the constant flow. And once you get a constant flow, you give them the fluid, okay, and then again go gradually up on the flow. Diagnosis, as I tell you, can be asynchronous breathing, hypovolemia, cannula malposition, or change in the patient position. All that can give us to chattering. Okay. If it is hypovolemia, you have to find out what is the cause for hypovolemia. Can be bleeding, can be new onset sepsis, or can be hypoproteinemia. Again, at what stage of your ECMO run it occurs, that is very important. Suppose it starts immediately after you initiate an ECMO. It can be either a surge reaction, but if it is constant, it can be because of the retroperitoneal hematoma. That you have to always keep in mind. Okay. If you see lot of fluctuations immediately after initiating the patient on ECMO, don't just think it can be a surge reaction. Yes, it is likely to be, but always keep in mind it can be a retroperitoneal hematoma also, and you have to be worried about that. Okay. Especially if the hemoglobin drops drastically, you have to keep that in mind. Okay. So if it is occurring after 10 days, 8 days, then a new onset sepsis can be one of the reasons. Sudden increase in the fluid requirement is one of the signs of sepsis in patient on ECMO. You might get most of the signs masked. You may not get fever, you may not get, counts may not be reliable. So the one of the early signs which can suggest of sepsis is sudden requirement in the fluid, and that tells you about the sepsis. And that is the way you manage the patient. If asynchronous breathing, you try to sedate the patients, or otherwise give fluids, albumin or blood, depending on how the patients are. Another thing that can happen is with the same RPM, the flow is reduced. So you don't see the fluctuating flow, but this is a constant flow, but it is reduced. So as I told you, it can be either a decrease in the preload or increase in the afterload. Okay. So you have to check the circuit, you have to see the cannula, you have to check the circuit pressures will tell you everything. If your P1 is negative, is becoming more negative, it means something wrong with the drainage side. If your P2 and P3 becoming more positive, it means something wrong with the return side. So that is the way you can differentiate this problem. Okay. Or if the delta pressure goes up, it can be something wrong with the oxygenator. And depending on whatever the cause may be, you have to treat. If pump pressure is more negative, it means hypovolemia or fluid issues, manage the fluid issues. If delta is high, it means the oxygenator is getting clogged and you have to change the oxygenator. And if P2, P3 both are high, then probably you need to look something wrong with the after the oxygenator. That is might be the kink in the renal arterial side of the return side of the circuit or in the return cannula itself, or there may be clot in the return cannula. Okay. 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 So I'll just go first to the hand crank. Okay. So suddenly the machine stops. Okay. What you need to do is call for the help. You need somebody to help you out in changing this. Put a clamp on the return side. Okay. Take this out. When you are taking it out, it looks simple, but remember each and every machine has got locking system. So you have to unlock this. If you try to just pull it out, your pump might break. Okay. So you have to be, there is an unlock system everywhere. Here the unlock system is like this. So you have to press this. Okay. And then you can put it inside, fix it, increase the, yes. Then move the pump. You can see here the markings 1500, 2000, 2500. So you have to increase your RPM to 1500. Okay. Once you do that, you have to release the clamp after you reach the 1500. You don't have to stop doing the hand cranking. Okay. Go back to the same RPM what it was originally. It was there, and go to that RPM and maintain that RPM. Situate the saturation and hemodynamic parameters remain stable. Till the time somebody doesn't come and correct it, you have to keep on doing hand crank. Okay. That is what the management of sudden stoppage of blood flow. If you see, it won't move in the other way around. It will move only in one direction. Okay. It won't move other way around. So if you try to do that, it won't move. You have to do it only one way around. Now it looks very simple, but the management of this starts when you initiate the patient on ECMO. Now why I say this? Because see, this is the length of the tube from the oxygenator to the ECMO. Okay. If both are kept very away from each other, you will not able to connect the pump. It will get stretched. Okay. So you have to always see to it that this hand crank has to be kept just below the oxygenator. It has to be fixed just below the oxygenator, because this is an emergency. If you try to search for a hand crank and then try to do it, you won't be able to do it. Believe me, you can't hold the hand crank and do hand cranking for more than 2 to 3 minutes. Okay, that's next to impossible. So it has to be fixed in such a way that the movements, see, now this is coming in between. If it comes like this, you will not be able to move it, isn't it? And if you try to forcibly move it, you might get entangled and something comes out. So you have to see to it, okay, it should be fixed in such a way that this pathway is free and you don't take much time to take the pump from the original pump to the hand crank. And that's why always keep it below the oxygenator, that is must. Okay. So that's about the hand cranking. The next is air in the circuit. Now air in the circuit can come either in the venous limb or it can come in the return limb also. Okay. So what are the reasons from where the air can come? Okay. Anybody can tell me? One is I will discuss cavitations can generate air per se. Okay. Anything get disconnected from the pre-pump area. Okay. Either there is a crack in the connector or there is a disconnection, three-way remain open, all that can suck the air from that side. Number 3, it can go from the central line. Because especially if it is a VA ECMO, your cannula is in RA, your central line is in RA. So if the air goes from the central line, it will directly come to the circuit. Okay. Or suppose your central line 3-way is opened, again it will suck the air. Okay. Another possibility is I don't know how many of you have noticed when I was taking a puncture here. Okay, the moment I disconnect the needle and try to put the wire into the needle, it has sucked the air. Okay, so that is what happens. Suppose you are patient is already on VA ECMO and you are converting from VA ECMO to VAV. So that time you are trying to put a jugular line. You take a puncture and then you try to put a wire. You can your cannula is in RA, which is draining, so it will suck because of negative pressures. So from the needle, the air can go enter inside. So when you are doing the VAV cannulation, you have to see to it. Once you do the puncture, ask somebody to clamp the lines so that there is no suction effect. You put a wire, and once you put the wire, let them release the line. So you might have to stop ECMO for 10 seconds or so till the time the wire goes inside. Okay, but that is essential, otherwise it will suck the air and then the air can go directly to the circuit. So you have to be mindful about that part. So these are the different sources from where the air can enter the circuit. Okay, now if it enters the circuit in the venous side, okay, you are not much bothered. Okay, now what will happen is, I'll show you. So you can see what happens when the air goes in the circuit from the venous end. So I put almost 10 cc of air. See what happens with that. All 10 cc of air is trapped in the pump. Nothing has gone to the oxygenator. So the centrifugal pump acts as it traps the air. Okay. So that is the first protection you can have it. Okay. It has not gone to the oxygenator. If at all it goes to the oxygenator, it will get trapped in the oxygenator. So again, oxygenator acts as a second trap. Okay. So that's the protection you can have it. Now, once the air is in the circuit, what will you do? Now there are two ways or two school of thoughts. Okay, one is definitely you have to remove this air. So what you can do is you can remove this air just by Now keep a watch on here. What you have to do is you have to just clamp the line, stop the pump. See what happens? The air moves up, okay, and it will go to the part which is. It will go up. As you know, air always moves up. Okay. So you can remove the entire air. Stop one completely. Okay. Okay. All the air will come out. Okay. So if the patient is stable enough, you can stop the pump and get all the air come out. If patient is unstable and you are taking longer time, what you can do is you can remove partially air and then continue the ECMO. Okay, because if the 10 ml of air is going in, it has not crossed oxygenator or not crossed the pump, 5 ml which is remaining may not cross the oxygenator. Okay, so in that case, because if you take a longer time to remove the air, if you are keeping the patient off ECMO for a long time, and that itself can be detrimental for the patient. So you have to always be mindful about that. Okay. So from wherever the air is, you have to just take it to the closest pigtail and remove the air from that side. Again, increase the RPM to more than 1000 and then release the clamp. Okay. If it goes to oxygenator, you don't have to bother, you don't have to even stop it. Most of the time the air moves up in the oxygenator. So there is always a purge line or pigtail line. From there you can aspirate air even without doing anything. Okay. If it goes outside the oxygenator, after the oxygenator to the return line, then it's going to be a dangerous scenario. First place, it will occur only if there is a massive air gets sucked inside, because after the pump is the positive pressure area, so the air does not get generated there. Okay, so the air going there is very less likely. It will occur only if there is a massive air which was being sucked in. Okay, but if it goes there, whatever is said and done, by the time you realize it and you put a clamp, the air must have entered the patient. Okay, because it is moving with such a high speed. Okay. If it is VV ECMO, still there is a and not much of an issue because it will get trapped in the lungs. Okay. If it is a VA ECMO, then you are worried. It can go to coronaries or it can go to the cerebrum. And in that case, what you need to do is you have to just give head low. The moment you realize the air is going inside, give a head low so that the air, if at all, it moves to the extremities rather than going to the brain and heart. Okay. So that is out of how we will manage air in the circuits. We'll discuss, we'll show you everything tomorrow when. Okay. Then you can get abnormal sounds from the machine. One of the sound which I told you is you might get crackling sounds because of the bearing which get broken, and you might get a crackling sounds. You might get a harsh sound, that is crackling sounds which can occur. Then another sound that you can see commonly is from the blender it comes. Okay. See, blender works only when the air pressure and the oxygen pressure are same. The central air and the central oxygen pressure are same, then on the blender works. So whatever level you keep it, usually most of the centers they keep it around 4 parts. Okay. So if it remains on that, it will work well. If any of the pressure goes down, okay, it will start giving you alarm. So alarm is saying that the pressures are not constant. And in that scenario, what will happen is, suppose your oxygen pressure is low, even your FI2 is 100%, only the air is going and not the oxygen. So FI2 ultimately becomes 21%. So and then patient can become hypoxic. So always if you see heard a sound like that, it means you have to think about some blender malfunction. Another problem that you can see is you can see dark color urine or a Coca-Cola urine, okay, or a hematuria. There are a number of reasons you can have a hematuria because patient is on antiplatelets, on anticoagulation, platelet might be low, or it can be hemolysis. Again, hemolysis can be because of either increased too much of negative pressure can lead to hemolysis, too much of positive pressure also can lead to hemolysis, or if there are some clots in the circuit, anywhere in the circuit can give us to hemolysis. So hemolysis can occur if there are any clot anywhere, either in pump, oxygenator or anywhere in the circuit. Also hemolysis can occur if the pump gets too old and too heated up. You can get a hemolysis also because of that. Okay. So you have to see, if you see dark color urine, the commonest cause is your hemolysis, and you have to find out the cause for hemolysis. How will you diagnose hemolysis? You can ask for urine hemoglobin urea, you can ask for a plasma free hemoglobin levels, and you can ask for LDH, bilirubin. All that investigations can help you in getting that, coming to the diagnosis of hemolysis. Again, depending upon the cause, whether it's a hypovolemia, whether it's a clot in the circuit, you have to manage that. So you have to look at the circuit pressures, and that will tell you about the, and you have to examine the circuit, that will tell you about the hemolysis, about the clot in the circuits or somewhere. So that is most important part that you should remember. Don't just ignore hemolysis, that will be just a part of parcel. Yes, some amount of hemoglobin is yes, but if it becomes too much, you have to manage it, and that's immediately reversible. Okay, the moment you change the circuit or components, it will get reversed. And this hemolysis can, remember that it can affect the kidney and can cause tubular necrosis, and your renal functions can go down. So you have to be mindful about that. Now what can happen to the pump? There can be a clot in the pump, or as I told you, there can be a bearing break in the pump. Okay. So how will you see? You can see clot visualized. Usually when the pump is running, you don't see clots. What you can do is you can do flash test. Means you just clamp the drainage line and open the fluids. Okay, priming fluid, what you connect, where you connect. You just open it up. Let the pump get flushed with the saline. So when it gets flushed with the saline, we will be able to see the clots. Okay, that is one of the flush test. What you can do it. Okay. So that is where you can see that. Or as I told you, when you auscultate, you get the sounds, or you can see the signs of hemolysis for the oxygenator or pump failure. I'll discuss on the management of pump failure and oxygenator failure together. Okay. Then you see abnormal circuit pressures. That's another thing which we see. What is more important? The trend rather than one single number. Okay. If the trend is becoming, P1 is becoming too negative, that is important. If your P2, P3 is increasing trend, that is important. Delta plus is increasing trend, that is important rather than one particular number. Okay. Always check for the calibration, look for hemolysis, that again suggests you of either too much of negative pressures or too much of positive pressure. Both are going to be dangerous, as I told you. Okay. And elevated delta pressure you can see is the oxidator clogging. Okay. If the P2 pressure goes more than 400, it can cause disconnection of the circuit also. So you have to be very mindful about that. It should not cross more than 400. Okay. And this is how you interpret the circuit pressures and your diagnosis. Okay. So if you have become too much of negative pressure, that means there is a preload failure. Okay, and you have to think about anything before the pump. If too much of positive pressures, both P2 and P3 both becomes too much of positive, that means after the oxidator, you have to think about cause after the oxidator. If delta pressure goes up, something wrong with the oxidator. And if your all pressures remains either the same or improves, okay, and you get with the same RPM the flow decreases, then that is something wrong with the clot in the pump. So always remember that if you have clot in the pump, you will not get change in the pressures too much, but with the same RPM the flow will reduce. So that's the most important sign which will suggest you clot in the pump. Okay. Oxidator issues, I think in the morning I discussed about the membrane edema or pulmonary edema. Plasma leak also I discussed. Or you can have a clot in the oxidator which can mimic like an embolus or can mimic like an VQ mismatch or atelectasis. Okay. So how will you diagnose oxidator problem? As I told you, increase in delta pressure, post oxidator period to start going down, and with the torch test you can see the clots in the oxidator. So I will show you how to change the oxidator and change the pump. I will change. Okay. So now if there is a clot in the pump or clot in the oxidator, you can either change the component or you can change the entire circuit. Okay, you can do either of it. Now can anybody tell me what is the advantage of changing the circuit and what is the disadvantage of changing the circuit versus the components? Yes? Yes, one is a big important is the cost. Okay, if you change the entire circuit, the cost is going to be 2.5. If you change the only component of the circuit, the cost is going to be might be 25,000 for a pump and 1 lakh for the oxygenator. So that is the cost difference. One. Second, surge reaction. Okay. The surface area, if you change the entire circuit, the new circuit comes into it. So the new surface, the big surface area is getting exposed. So you get a new surge area. Is it as if you are starting a new ECMO per se? Okay. If you change only a component, again the surface area is going to be less, and that's why the surge reaction is going to be less. Number 3. Yes, your drug requirement, those which get adsorbed to the circuit, again drug requirement will increase because now new circuits, so new adsorption will take place. The previous circuit might have got saturated, but now the new circuit, so new drug get adsorbed, so your drug requirement will increases. Fourth, you might require blood flow priming. Okay, if you change the entire circuit, because again the circuit volume is around 700 ml. Versus if you change the components like pump, if you change it's only 50 to 80 ml. Oxidator if you change it's going to be 150 to 200 ml. So you may not require blood, but if you change the entire circuit, you might require blood for the priming also. Okay. So that is the advantage and disadvantage of changing the oxidator or changing the circuit versus oxidator. Okay. Now whichever circuit you want to change, there are few steps which are constant. Okay. First, whether it's an elective or it's an emergency. If it is an emergency, you have to change, you don't have much time to prepare. Most of the time, if you are vigilant, it is going to be an elective procedure. So when you see your delta pressure is increasing, it's going to be an elective procedure. Okay. So what you need to do is, one, you have to manage this patient, because when you are going to change this, you are going to change it, that time you are going to stop ECMO. So ECMO is going to stop for a 1 minute, 2 minutes, 3 minutes, whatever the time you take, that time is going to, the ECMO is going to stop. Some of the patients are ECMO dependent. So what will happen is they will not tolerate the stoppage of ECMO even for 1 minute, and they can develop bradycardia and they can go into even cardiac arrest also if they are ECMO dependent completely. So what things you can do to prevent this? One is meticulous monitoring, so you diagnose as an elective procedure rather than emergency. Second is before, so when this thing occurs, you have to divide your team into any complication for that matter of fact during ECMO occurs, you have to divide your team into 2 parts. One is going to manage the patient, one is going to manage the circuit. So divide your team in 2, one is going to manage the patient, one is going to manage the circuit. Okay. Those who are going to manage the patient, they'll have to do everything as if patient is not on ECMO. So they have to go up on the inotropes, they have to go up on the ventilator settings, okay, and they have to manage the patient as if he is not on ECMO. Remember that this patient can go into cardiac arrest, so you have to be ready with the CPR and everything. Okay, that's one thing. Okay, the team which is going to manage the circuit, they have to prime the new components. Okay, the new circuit or new components, they have to prime and keep it ready. Okay, so first thing is that now suppose you want to change the pump, you have to prime. Okay, you have to prime this and keep it ready. That's the first step that you have to do. Second thing is you have to remove these components. So you have to remove the pump. So what you need to do is you require first of all 6 clamps, 2 clamps to put on the return side. So you put the clamp here, one, you put another clamp here, you put 2 clamps here. So the 4 clamps and the 2 clamps are there with the new circuits. Okay. That is one thing. Okay. Second thing, what you need is, see, the tube cannot get connected directly to the tube. Okay, it will be connected with the help of connectors. So either you can preserve the connectors in the circuit, or the new circuit which are connecting, you take the connectors. The best and easiest way is keep the connectors in the new circuits, so you remain the same standard things. Okay. Then when you are changing the pump, first you require here 3 persons. One who is going to change, one who is going to put the clamps, and one who is going to get the pump speed down and remove the pump. Okay. So now once you put the clamp, okay, you have to cut the tube. Okay. So you are going to cut the tube. Okay. And once it is connected, you have to see to it that there is no air that comes there. Okay. Okay. First remove the drainage side clamp or venous clamp first, and then the return clamp. Okay. Okay. Fine. So that is the way you should do it. Now it looks too simple, but when you do it, what are the problems that can come? One is you might not have taken a connector in the new pump, and there is no connector in the old pump also. So you will not able to connect it. That becomes the biggest problem. Then you search for the connectors, and then that becomes a headache. Okay. Second thing, as you see, the air can go in. Okay. So that is third thing is to be coordinated work. Everybody should know what is their work is. One person is going to just hold the pump, is going to stop the machine, take the pump out. One person is going to put a clamp and cut the tube, and one person is going to connect the tubes. So this is the third, all three people should know what is their work is. Same thing when you want to change the oxygenator, the steps going to remain the same. Only thing is that when you change the oxygenator, you are not doing anything with the external motor drive. So you don't require to come down on the ECMO speed. You don't have to come down on ECMO RPM. You just can directly put the clamp on the pre-oxygenator side and post-oxygenator slides, cut the oxygenator, connect the oxygenator. Okay, that is one thing. Second thing, don't forget to connect the oxygen to the oxygenator, to the new oxygenator. Most of the time we just connect this and we forget to put this connection to this. If you do that, what will happen, whatever blood comes, that will go through oxygenator without getting any oxygenator or gas exchange. So that is most important, you have to remember. And third, as I told you, there are 6 outlets. Okay, so you have to connect the water in and water out, otherwise patient will develop hypothermia. So all these things you need to do it when you change the oxygenator. Okay. Again, this you are going to repeat when you are going to do it tomorrow. Okay. These steps, everything is being given in the books, so you can go through the book. Okay. For today, so before you come for the tomorrow's round. Okay. Then you can have both the tube becoming same color. Okay. Both becomes dark red, both becomes bright red, and there can be another different still diagnosis. If both are dark red, that means the sweep gas is not connected. There can be a blender malfunction, or patient has been treated with methylene blue, so you might see that both the tubes are dark red. Both are bright red. If it is in VV ECMO, it is a recirculation. If it is in VA ECMO, either there is a wrong connection or a line swap. Okay, or patient is in a severe catastrophic stage that there is no tissue uptake, and that person probably is going to not survive. There is hardly any tissue uptake from that patient. You can have sudden no flow. Okay, so your pump is working. Previously what we discussed is sudden stoppage of pump. Pump stops. Here sudden no flow. Pump is working but there is no flow. Now if you see no flow, it means there has to be some clot somewhere, either in the drainage side or in the return side or in the cannula. So there is clot somewhere, big clot which has come and stopped either of these. Okay. So that causes a sudden no flow. And again this is going to your dreaded complications. Why? Because if the cannula gets blocked, okay, it means ECMO is stopped, number one. Number two, you have to remove that particular cannula which is blocked, okay, and to restart you have to put another cannula. Okay, that is one thing. At the same time, the cannula which is existing, you have to keep maintain that cannula, otherwise that cannula will also get clot. And third thing is, you might have to preserve the circuit so that that does not get clot. So then you have to put the circuit into a recirculation. So you have to do many things if the cannula gets clotted. Okay. So if the venous cannula gets clotted, you get P1 becomes 2 negative. If the return cannula gets clotted, P2, P3 becomes more negative. Okay. And what we will do is, you have to, how will you diagnose whether it's cannula or oxygenator? It's very simple. You put a bridge, you clamp the cannulas and open the bridge. If the circulation is very good in the circuit, it means it's nothing wrong in the circuit. It is either a venous or a return cannula. If circuit is blocked, it won't move in the circuit itself. Okay. So that is the way you can diagnose. And second way is, looking at the circuit pressures, you will be able to diagnose where it can be the blocked cannula is. Okay. So as I told you, how will you manage blocked cannulas? Okay, first diagnose which cannula is blocked. Okay. Plan whether patient requires ECMO or can you come off ECMO a little earlier. Okay. If the patient is better, is on improving side, you might accept little higher ventilator settings and you might think that will let the patient to come off ECMO. Okay. If patient is still ECMO dependent, you have no other choice to arrange for another cannulation and initiate ECMO. And then in that case, you have to preserve the second cannula which is existing. So you have to always keep that in mind. And that cannula you have to keep on flushing with the saline so that it does not get heparin 9 saline, so that it does not get clot. Okay. And the cannula which is clotted, you have to just take that out cannula. If it is a venous cannula which is clotted, you have to just pull it out and take a purse string suture there. If it's the arterial cannula which is got clotted, you have to call a surgeon, ask him to remove the arterial cannula and even do a Fogarty because the clot might have gone somewhere else also. So you have to do a Fogarty and remove the clots from the arterial cannula if it is blocked. Okay. So the another complications some of you do experience is the accidental decannulation or circuit disconnection. Okay. And that can be catastrophe as you know. It might be a return or drainage cannula. If it is a return cannula, there will be excessive bleed and patient dies. So it's not only, it is something more complex than a blocked cannula. In blocked cannula, what happens? ECMO stops. Here also ECMO stops. But this is in addition to blood loss, okay, or air in the circuit and the air in the patient also. If it is a drainage cannula which comes out, the air will suck in. If it is a return cannula which gets come out, then there will be bleeding. Okay. So that is, the management is going to remain more or less same as a blocked cannula, but you have to take care of hemorrhage. So you have to give fluids, you have to resuscitate with the fluids, okay, and you have to take care of air if at all it enters the patients. So that is the management of accidental decannulation. Okay. And the last part of it is hypo or hypothermia, and that can occur because of heater malfunction. So if your heater stops functioning, okay, because the ICU environment is cold, when the blood comes out, it can become cool and you can have a you can have a drop in temperature. Now usually we are not used to measure see temperatures in ICU. Okay, so this is the one which get ignored. For all the patients in the ECMO, you should have the core temperature monitoring. So you have to put a rectal probe to monitor the temperature. Okay, that is important. So how it will present? Hypothermia, you might see sudden increase in saturation. Okay, you might see patient metabolic activity will come down, so there may be bradycardia, you might see arrhythmias, and you might see a coagulopathy. So all that can be a part of hypothermia. So don't always feel that if the saturation is better, things are better. You might be a hypothermia might be the cause for drop in saturation, and you can have a hyperthermia also if it is malfunctioning. Okay, so that hyperthermia can lead to again hemolysis. So there is a heat exchange failure, and what is the management is you have to just change the heat exchanger. That's it. And what can be the complications related to circuit? There can be a circuit disruption, there can be a clot in the circuits, there can be air in the circuit, power failure or accidental decannulation. This is all I think I already discussed this. Thank you.